I think it's working. I pressed the button.
Okay. 1 second, I'll share. Okay. Hi, everyone. Welcome to the Ivy Lab meeting for November 2025. Our guest speaker today is Dr. Austin Jones, and he'll join in at the conclusion of these slides. So just some updates on our published manuscripts. We have the neurofunctional phenotyping to investigate the role of the orexin system at the intersection of opioid use disorder and insomnia, a protocol for a randomized placebo-controlled clinical trial of luborexant in patients with insomnia receiving buprenorphine. Our next manuscript is called The Integration of Substance Use Interventions into Reproductive Health Care. Our third one is Inpatient Buprenorphine Initiation for Treatment of Opioid Use Disorder in Pregnancy and Postpartum. And our last one is Sex-Based Differences across the stages of the addiction cycle among adults with severe alcohol use disorder. Congratulations to everyone. Our manuscripts in review, the first one is called The Resource Utilization Among Racial Subgroups in an Integrated Obstetric Addiction Clinic. The second one is called Screen and Say, Just Don't Drink, a systematic review of international guidelines for treating alcohol use disorder in pregnancy. And our last one is Postpartum Buprenorphine, a descriptive analysis of dose adjustments and treatment retention. So we're excited to push those over, hopefully in the next couple weeks. Some of our social media pages includes this on Twitter/X. This is our YouTube channel where our Ivy Lab monthly meetings also are posted. Here's our LinkedIn and our Instagram. Please make sure that you're following our pages to stay updated with all things Ivy Lab. Here are our lab leads. We have Arjun for media, Dr. Marcus for regulatory data, Amber as the coordinator, including myself. We have James as community management. We have the other Michelle as an interventionist, Dr. Jones as regulatory data, and our presenter for today. And then we also have Nicole, who is data regulation and an interventionist. Our current studies include Project SORT, which is still investigating the relationship between sleep and opioid use disorder recovery. This recruitment is complete, but we are still reviewing charts. The registry study is led by Amber, which is tracking clinical outcomes of pregnant and postpartum patients who seek addiction treatment with our OB Motivate clinic. Our recruitment is complete and charts are also ongoing. CBTIO is led by the other Michelle and Amber. It is the adaptation of cognitive behavioral therapy for insomnia, specifically for people with opioid use disorder. Recruitment is active, and we're using SORT data, which is one of our other studies. Luborexant 2.0 is led by Dr. Jones, Dr. Marcus, and Kaylee Swan. It is a medication treatment study testing the effects of luborexant on insomnia and impulsivity among people with opioid use disorder. This is currently active. Suvorexant is led by Dr. Austin Jones and Dr. Madison Marcus. It is a phase 3 double-blind randomized controlled trial of suvorexant versus placebo on insomnia among people with opioid use disorder, and this study is currently in the planning phase. We also have Project Castle, which is led by Dr. Jones and Amber, which is developing a computerized intervention that educates pre-medical professionals and medical professionals on substance use disorder stigma. This study is in the pre-testing phase. We have some other educational studies, which is the clinical research curriculum, which is ongoing and active. The students of this study have just presented at the VASAM conference, and they submitted their abstracts and presented their posters at this conference in Roanoke. The study leads are Dr. Jones and Nicole. We have the First Steps project, which is addressing maternal morbidity and mortality by adapting a patient navigation model for birthing people with substance use disorder. And just a recap of the VASAM conference, special thank you again to the students who submitted their abstracts and presented their posters. Here's a group photo of everyone. I hope you all had a great time. Everyone looks so photogenic. I was telling Arjun that. Just want to let everyone know our next lab meeting will be posted via email. I'll be sure to update everyone, so please be on the lookout for that. Thank you for coming today, and feel free to reach out to me at my email for any questions or updates. And now I'm going to turn it over to Dr. Austin Jones for our presentation.
Thank you very much. Okay, let me try to share this screen. Wait, hold. Okay, can everybody see this like normal instead of my presenter version?
Yes.
Now we can. Yeah, you're
Okay,
good.
okay. Had to switch it around. Okay, so basically, today I'm just going to be talking about a study that has been conducted before in the Ivy Lab. We're going to be talking about medication class prescription receipt by insomnia symptom in adults receiving buprenorphine for OUD. And I'll go into more because I tried making it a fancy title, but I'll go into more of the specifics. So first of all, kind of wanted to touch base a little bit on the background. So sleep disturbance is common in people with OUD, especially on buprenorphine, and it's been linked to poor recovery outcomes. And in addition to that, we've also seen that in claims-based studies where they use insurance claims, we've seen that around 50% or more of adults on buprenorphine report clinically significant insomnia, and that these people with this insomnia are frequently prescribed sedatives or hypnotic medication to try to treat these insomnia symptoms. However, this can lead to potential risk, as you know, with opioids and any type of potentially benzodiazepines or anything that could be a depressant on the body. So these are always things to look out for. But one thing about these claims-based studies that we see is that it may miss undiagnosed insomnia. So what I mean by that is that these claims-based studies, they use insurance claims data, so they had to have been prescribed or had to have been diagnosed as having insomnia versus people who may not have been diagnosed with insomnia, but they are reporting to have insomnia symptoms or all the symptoms related to insomnia. So these claims-based studies would not capture the whole picture of the people who have OUD and are on buprenorphine, but also experiencing insomnia symptoms if they haven't been diagnosed with insomnia. So that's kind of what this study is about, is that we wanted to look at more of the symptom specific aspects of the insomnia, and just instead of looking at claims data, which we have done in the past. So this is a study that we have done in the past from the Ivy Lab. And in the past study, what it was is it was a retrospective study that used national insurance claims, as I mentioned before, where, of course, you would need to have a diagnosis of insomnia. And this paper, what it found was that there is a high use of sleep-related medications after starting buprenorphine. And in this study, we divided them into different categories or different classes. So what we have is benzodiazepines as one, Z drugs as another, and in this paper we had other, which encompassed melatonin type drugs or any medication that would be used like an off-label for treating sleep or insomnia, things like that. And I'll go more into the specifics on those medications in a minute. But for the current study that I'll be presenting on, we're actually looking, or this one was more of a cross-sectional study. So we had participants do self-reporting using a insomnia scale or an insomnia index, the ISI. And so we were able to look at their symptoms and see if they qualified for having insomnia based on their total score of, I believe it was greater than or equal to 11. The higher the score, the more likely an individual would be to have insomnia. So for the study that we were, or that's currently ongoing, or that we are working on and I'll be talking about today, we looked at the medical record. So instead of doing, doing the insurance claims or looking at that type of information to look at their prescriptions and to see what medication they're on, we decided to look at their medical records and we did medical record abstraction just to kind of get a feel for all the different types of medications that they are on. And we also, for this paper or for this study, actually, we were just focusing on the frequency. So how often are these medications, how often are these different types of sleep medications prescribed, and the association of these sleep medications with different symptoms of insomnia. So for this study, we didn't just look at insomnia as a generic overall thing. We split it into different domains so that we can see the specific insomnia symptoms that we might see with like the prescribing increases and seeing if they're associated with any which way sleep related medications with each ISI or each insomnia domain. And I will go more into that. So kind of more of a bigger picture. So what this study, what we're asking is, do the ISI sleep problems, so does the survey, the ISI, the sleep problems in there align with medication types? So do we see any type of association with the different medications that are prescribed to these individuals versus the insomnia and the different sleep problems that will be identified in the ISI survey? And as I mentioned before, we're looking at the frequency. So how often are these prescription or how often are these medications prescribed to these individuals? And what's the association of these medications with the individual domains of the ISI? And then basically the why are we doing this? Why are we looking at this? This will basically be able to just give us an idea of what's being prescribed, and we can go from there and make decisions based on how individuals who have insomnia, at least by the ISI, how they are being prescribed by OUD medication providers or OUD providers and clinics. So we'll be able to kind of get a more safety and a more targeting aspect by looking at this information, even if it's like the frequency and association. So the methods for this current study is, as I mentioned before, it's an observational cross-sectional survey with medical chart abstraction. So we had the participants complete the self-reported ISI survey, and then we also took their medical chart and abstracted the prescription medications that they had on their profile. For the population of interest, we were looking at adults anywhere between 18 and 65 years of age who were stabilized on buprenorphine and were in an OUD treatment. So Motivate is where we typically got our participants from in this setting. And for the measures, as I mentioned before, we are looking at the ISI. So the ISI is a series of, I believe it's 16 questions or 15. But the ISI is basically, it's split into different domains. So different symptoms of insomnia. And for the ISI, those symptoms are falling asleep, staying asleep, and then waking too early. So what we've done is we are looking at how the sleep medications, how they relate to these individual domains. So what's the association, the frequency of being prescribed these medications for falling asleep, staying asleep, and then waking too early. And for the medications that we were concerned or we were looking at after that one paper that saw an association between the sleep medications and they had classified the other off-label medications, these are kind of the classes that we've kind of bullet it all down to. So we've got benzodiazepines, which include lorazepam, clonazepam, diazepam, alprazolam, all the AMPs. Then we have Z drugs, which are your non-benzo hypnotics or non-benzo sleep medications. So that would include things like zolpidem, anything like Lunesta, drugs like those. And then we also got melatonergic drugs. So a lot of times this will be either the prescription Ramelton, or you can have uh, the actual supplement drugs. So you could have like the actual melatonin supplement that you can get over the counter. And so those were the classifications of the drugs. So for each one of these ISI symptoms, falling asleep, staying asleep, waking too early, we're going to be looking at the frequency of these 4 drug classes with each one of those insomnia types. So that way we can see the frequency and association of them being prescribed to individuals reporting insomnia or not. So our analysis of what we did is we did a 2-by-2 comparison. So we were looking at people who reported having some type of insomnia symptom versus people who reported not having any type of insomnia. So their score was below the threshold on the ISI. I believe it's below 11. And then we also looked at whether or not they had medications present that fit these categories or these classes, or if they were absent. So your standard 2-by-2 comparison. And then we did a chi-square or Fisher's exact test, also reporting odds ratios as well. And I'll put more into those. So for the basic demographics results that we were able to see, the mean age of the participants who were in this study was around 40 with plus or minus 10 years. About 60% of the sample were women, and 36.8 identified as Black or African American, while we had 55.1% as white. And then the majority of the participants, around 80%, did not identify as Hispanic or Latino. Then going more into their buprenorphine dosage and their formulation, for these participants, we found that 88.2% received sublingual buprenorphine, so that could be film or tablets, and then only 11.8% of the study group sample size that we had received Sublocade or a monthly injection. And for the individuals who are on buprenorphine, we looked at the duration on buprenorphine in years for overall. Then the sublingual, those were on the sublingual. We looked at that duration as well as Sublocade. So what we found was that overall there was individuals had an average duration of receiving buprenorphine as treatment for about 1.86 years, give or take 1.6 years. And then for the median sublingual dose, what we had was we saw that there was for the actual sorry, not dose duration, we saw that it was about 1.8 years as well. It's very similar to the overall. Then Sublocade, that one's actually a little bit longer. That one was 2.3 years. So those are the durations for the individuals within this current study. And then looking at the dose, we see that for the sublingual individuals who are taking the sublingual buprenorphine, we see that they had a median dose of about 20 milligrams per day. As well as when looking at the Sublocade dose, we see that there was it was split in between different doses. We had a 300 milligram, and of the individuals who were on Sublocade, 16 of them, 13 of them were on the 300 milligram dose, with only 3 of them being on the 100 milligram dose. So we just wanted to make sure that people were, staying on their buprenorphine so that they would be included within this study and that they were stable on it. So now we're going more into the different aspect or the different domains of the ISI, the insomnia survey that the individuals did themselves. So as I mentioned earlier, for each one of these insomnia domains, we were going to be looking at the 4 different drug classes. So for this domain, difficulty falling asleep, these are the prescribing patterns of the 4 different drug classes that we identified. So as you can see here, we see that benzodiazepines there wasn't any significant one was prescribed more than the other. We just see that it is basically a heterogeneous prescribing for all these individuals with a mixture of benzodiazepines, Z drugs, melatonergic, or other, depending on what they what they have and what they're presenting to the clinic. So for these, we had the benzodiazepines. As you can see, we had individuals who were on or who claimed that they were having difficulty falling asleep. About four of them, of the people claiming to fall asleep, four of them were on were on benzodiazepines, and nine of them were not. As well as the looking at the sleep drugs. So the non-benzodiazepine hypnotics, we had three of them were not on there, or were, I'm sorry, three of them were choosing that they said that they had difficulty falling asleep. And nobody who was taking a Z drug said that they did not have difficulty falling asleep in this study. And then melatonergic, it was the same across both. It was a 5 and 5. Five participants reported having the difficulty falling asleep, and five of them didn't. But yet they're taking melatonergic. So five are taking melatonergic drugs, even without the insomnia or reported insomnia from this ISI scale. And then the other classification of drug, this includes other medications that would fall into the category of being used to treat or used to help some of these insomnia symptoms, but yet they're used off-label. So that would include things like hydroxyzine, gabapentin, some SSRIs, trazodone, drugs like those. And later I go more into, or I mentioned the specifics if you wanted to look more into those. But since that includes a larger amount of drugs within this category or class, that's why we see that there's 55 participants who reported having difficulty falling asleep that were within this other class of prescriptions or other class of medications being prescribed to them. And then 42 reported not having difficulty falling asleep. But as you can see here, none of these are significant differences in between the two. Though the other does get close, it could be just because of the sheer number. Now we're looking at the next insomnia domain, or for the ISI, and that is difficulty staying asleep. So here we're also looking again at benzos, Z drugs, melatonergic drugs, and the other. And it's kind of similar patterns, except for in this one, you see that there is, for benzodiazepines, there is actually a significant chi-square test. So we do see that there is actually more individuals are reporting using benzodiazepines while not actually having a significant, or while actually reporting to not have difficulty staying asleep, as opposed to only four participants who are taking benzodiazepines say they are having difficulty staying asleep. So that is actually a significant difference in between those, the four saying they didn't have difficulty or saying they do, and then the nine saying they don't have difficulty staying asleep. And, and yeah, as I mentioned earlier, this is very similar patterns to the difficulty falling asleep, with the other classification having the highest amount of individuals saying yes or no, just sheerly on the size of the amount of drugs that fall within that category. And then the last insomnia ISI domain that we'll be looking at is waking up too early. And so this one also, like the falling asleep or difficulty falling asleep, there are no significant differences here, with similar prescribing trends, as you can see from the other domains that were mentioned, the other two. So for this one, we've got 6 individuals reported they were waking up too early. They were taking benzodiazepines, while 7 individuals reported taking benzodiazepines without without waking up too early. And that kind of continues. We go to Z drugs, which are very low. We've got 1 who was saying that they were waking up too early, who reported taking a Z drug, which would have fallen into the non-benzodiazepine drugs. And then for melatonergic, we see there's more people reporting the waking up too early, and those individuals, there's 7 of them they reported waking up too early, and they're taking the melatonergic class of drugs, as opposed to 3 of them who are taking melatonergic drugs. They only they do not report waking up too early. So basically how we've kind of come to the conclusion or kind of looked at this is that we see that the prescribing of targeted hypnotics did not vary by individual ISI domain. So the falling asleep, staying asleep, and waking up too early. We saw that it wasn't specific and it did not vary meaningfully in between those, but that just highlights the point that it is a heterogeneous kind of mixture of the different the prescribing to try to treat these comorbid conditions that seem to be occurring with these participants. And we also found that most of the providers or most prescribing that these participants have received with these medications, these sleep related medications, they're being prescribed these medications by OUD clinic providers, so clinicians at Motivate. And these individuals, though highly trained in what they're doing with buprenorphine and OUD, they are not the individual participant's primary care physician, so they don't know their whole history of anything that may be a comorbid condition, as well as they aren't licensed or trained psychiatrists. So a lot of times they will not have the proper training or the knowledge set to be able to say which medications should they be prescribed that fall within those medication classes we just covered, the benzodiazepine, Z drugs, melatonergic, and then the others that are sleep related. So that's kind of one kind of instance that we've seen that may kind of highlight why we see a lack of significant finding on any of these. And it likely, the reason or the prescribing by OUD clinic providers, this likely reflects the priorities of OUD care. So they're in Motivate, so they are receiving OUD care, which could include maintaining their MOUD stability, avoiding any potential benzodiazepine risks, using familiar off-label agents for comorbid mood, anxiety, or pain. So there will be medications that maybe these prescribers at Motivate, they will be prescribing these medications as off-label effects to try to treat these different comorbid conditions or comorbid like symptoms that these individuals are reporting to have, and without being actual their primary care physicians or licensed trained psychiatrists, they're kind of using their knowledge of what these medications can do to kind of help alleviate these symptoms, but without actually tackling or being a primary prescription medication being prescribed to them specifically, like they are doing with like buprenorphine or things like that. Then most patients or most participants with this in this study, they used off-label medications, like I just mentioned. So most of them fell within the other category. And kind of like a recap, the other drugs include like SSRIs, trazodone, mirtazapine, gabapentin, quetiapine, and hydroxyzine. So those are just some very commonly prescribed sleep medications that aren't necessarily FDA approved. They aren't licensed and they aren't approved to be able to or be used for that. They are used for off-label effects. They're on the FDA label. They are used to treat other symptoms. And so what this may be showing is that this prescribing pattern and this prescribing frequency that we saw with the different domains, it may be related to the prescribing is driven by comorbid choices. So the mood, the anxiety, the pain, and then any distress that comes with insomnia comes with any of these aspects of the ISI, or having OUD and then taking buprenorphine and then taking these medications. These seem to be trends that show that they are trying to treat these underlying these comorbid conditions and maybe not necessarily treating the actual insomnia in and of itself. But the nature of this study is still we're trying to figure out the exact reasoning behind why we see or do not see these significant findings with prescribing these different medications across these different insomnia domains. But that's something that I kind of wanted to open up to the rest of the lab meeting and just get people's thoughts and ideas. And, you know, maybe somebody has an idea as to why this prescribing pattern is shown or why we saw what we did. So if anybody has any type of suggestions or maybe a possible idea, I would love to hear it.
Awesome. Thank you, Austin. That was really good. I know it's been good to be able to look at this data and get an idea of a good snapshot of what's happening at the Motivate Clinic in a clinical context. So yeah, I just gonna work, like Austin said, he's in the process of kind of working on this data and working on getting it written up and getting it out there. This is an area that there's not a lot of very clinical research on. So I'll open it up to people's feedback, any questions or any thoughts that you have based on the questions that he posed back to the team.
I have a question, Austin.
Hmm.
So I'm very familiar with the EMR, looking through those at Motivate and looking for sleep medication. So the first one I was going to ask is just um, when so the first study that was published that it's kind of related to, I saw
Hmm.
that was focused, I think in the methods it said the first people who had been on Suboxone for less than 6 weeks or something like that.
Hmm.
Um, and so one of the things in my mind that might be related to why someone gets prescribed a certain medication is like its misuse potential. And if there's some sort of like trust that evolves the longer a patient has been in treatment for their substance use disorder. Um, but I'm just wondering if you all had data on that, on like it looked like the study you just did, they were in treatment for a lot longer on average. Um,
Mm.
but I'm wondering if you all have thought about that at all.
That's an interesting question, and I will work with Michelle. She was the one who was actually she was able to grab the data and very, very wonderfully send it to me, so I was able to do these analyses. So I can work with her to see more about if that is data that she does have, or we can kind of like pull that out. But if not, that is something interesting to kind of follow up on and look to see if it's something about like their extended period being within the treatment clinics versus them being prescribed these different types of medications.
Hey y'all, I'm here. Yeah, I'm back. I'm not back from maternity leave, but I'm just like getting back into things. So it's good to see some faces, but I can quickly answer this. It's a really good question, James. So the study that this is from SORT. And so as part of SORT, they had to be on buprenorphine for at least stabilized on bup for at least 6 weeks. So we don't have data for less than 6 weeks, but I think it's an interesting question of those stabilized, for longer term, if the patterns of prescribing would be different than those, who've been on bup less than 6 weeks.
Hi, this is Maha Alatar, one of the sleep physicians here at VCU, and a very nice job, Austin. That was
Thank you.
beautiful. So good work.
Oh, thank you.
Yeah, very nice. So, question, the ISI, the questionnaire, when was it given? At what point is it proceeding? I assume they gave it, they scored on it, and that's when somebody somehow initiated sedative hypnotic, right?
Mhm.
What's the date? At what point was it given? No. Yeah.
Yeah, Austin, I'm happy to field this because this is a SORT methodology question,
Oh,
but it was a cross-sectional study. So it was just a survey that we gave at one point in the clinic. So it was just kind of a snapshot of what was already going on with the patient at that time. So it didn't relate to any prescription of hypnotics or prescription of bup. It was just gathering information about their insomnia symptoms when they enrolled in the study.
So it's possible that the questionnaire was given after the sedative hypnotic was given. Is it possible?
Oh yeah, absolutely.
Okay. So, that kind of changes things a little bit. Because, it's, yeah, you know what I mean.
mhm.
Yeah.
So the other question I have is, this is more of a comment. Was is more of a comment is that it's interesting that the prescribers try to gear off the benzos, which is very, very reassuring, and went into this other trying to make sure that there's, I assume, no effect on the respiratory system. But gabapentin does have a little bit of respiratory suppression, just so you know. So we try to avoid that, maybe in higher doses. The other thing is just to note, that's something you may want to consider to put in your paper if you want, is that the sleep literature, the American Academy of Sleep Medicine practice guideline, if you go into their website and you pull the practice, called the practice guideline, maybe I can try to find and send it to you, on insomnia, like the American Academy of Sleep Medicine, if you go to their website, they have practice guideline for different sleep disorders, like sleep disorder breathing, i.e. sleep apnea. They have it on circadian rhythm, and they have one on insomnia. It's a little outdated. I think they're working on a new one. But you will see that, for example, there are medications that, you know, they have evidence that they work, but they specifically do say that they do not recommend trazodone. And also in the literature, I don't know if it's in that practice guideline, we in the sleep medicine community, we were told not to give quetiapine. So we don't use it. Yeah. So there are some of those medications that are being prescribed for, you know, I guess you can find anxiety, pain, and so forth. But if it's strictly for sedative hypnotics, we're not supposed to. Not to say that we don't use it. Have I used it? Sure. I mean, when I get desperate, I do use them. But I am going sort of against practice guideline, but I have to justify it. Yeah. You know, so just want to throw that in.
Oh, that's great. Thank you. That's really interesting because this is what I'm wondering if it was more related to these these comorbid effects, because these are not their PCPs or their psychiatrists. So I'm wondering if that's kind of like related to that aspect.
Yeah. Yeah. I mean, you know, we do use them, and I do have a question. So I know that with the ISI, you mentioned there's a sleep onset and sleep maintenance, waking up early. Were you able to put more than one of those categories together and look at it? Because most patients will not have one. If they have a sleep onset, they may have sleep maintenance, vice versa, you know what I mean? Especially the sleep onset and sleep maintenance, they go hand in hand a lot. So maybe if you want to look at that together, when they have both symptoms together, what do you get? It would be interesting to see.
Yeah, I think that would
Just a
be
suggestion.
No, I think that'd be a really good idea, because I know from very little of the sleep studies that I had in grad school, and that there are certain people who will have, like, of these three domains I mentioned, a lot of them will have two, maybe not three, but they often overlap with each other. So that would be really interesting to see.
Overlap.
Yeah.
Yeah, the overlap. Yeah, a lot of them do actually. So yeah, I mean, that's what I have. And then this is not part of, I mean, you didn't look into that, but just for everybody, it's something to keep in mind is, if you look at the practice guideline, then your recommendation is that cognitive behavioral therapy for insomnia, CBTI, is highly recommended at first line. They're kind of shying away from that and going, you can prescribe a sedative hypnotic, but incorporate CBTI. And so that would be something to look and see if any of those providers recommended CBTI or not. That would be an interesting
that would be
feed
really
into it.
interesting.
Yeah. If you want to explore that, whether CBTI was mentioned, was ordered, was recommended.
Yeah.
Yeah. Because we do that a lot in our clinic. It's in the practice guidelines. So
okay.
Thanks, Caitlin, for sending it.
I will just point out, Dr. Alatar, just a big limitation of this study, and actually, ironically, the big claims data study that we had published a while ago, is that the indication for the prescription is not something that we have data on.
Okay.
So none of these medications, we cannot say that these medications were prescribed for insomnia. And to tell you the truth, I don't think they primarily were.
Mm.
It's just getting a snapshot of these are patients who have these insomnia symptoms. We're just trying to describe like the meds that they're getting.
Ah,
I
yeah,
think
I
what's
see.
driving a lot of this, like gabapentin, is so prevalent in this patient population, mainly because of the comorbid pain disorders, which are
Right.
so overlapping with opioid use disorder.
Sure.
So we just can't speak on that. And that's a limitation in
Oh,
this.
I got you. Okay, I see.
Yeah.
Definitely. Okay, cool. Yeah, thank you.
And then I don't know if we have CBTI. Like, I think we, Michelle will know if we ask them if they're getting CBTI. I don't know. I don't think we abstracted that from the charts. I bet if we had, we wouldn't have found too many because at Motivate, we typically have not had we've had a dearth of behavioral health providers, um,
Yeah.
let alone someone who does CBTI. But we did ask in the survey and the SORT study if people would be interested because we use that data as preliminary data for the R34 grant that we have, which is testing a CBTI intervention in this patient population.
Okay. Yeah, yeah. Okay, great. Thank you. So I do have another question. I think I brought this up before in other scenarios, is the word insomnia is
Mhm.
very general. So are you, I mean, you may want to clarify, you're just putting it in there. It's insomnia symptoms versus insomnia disorder, versus secondary versus primary. There's all these things. So you may
Do
want
you have
to.
like do you have like any specific like that many people like for those three domains, do you have
Mhm.
any like specific like ways that you categorize them or describe them as opposed to just insomnia domains?
I would just specify somewhere in the paper that you're using the word, define your word of insomnia. Just say that, I would say based on what I can see is that your description of insomnia here is a symptom.
Okay.
And I would define that and say from now on, you will use the word insomnia, but what you really mean is the insomnia symptom. Because in order to call it a disorder, you really have to do a lot of workup. And we're just having it very, very general. We're just using it as a symptom, not a
Okay.
disease.
That makes sense. That makes sense.
Yeah. Like, there's so many types. There's psychophysiological insomnia, there's secondary insomnia, there's primary insomnia, and there's like a whole list of insomnias, that paradoxical insomnia, and on and on and
Oh.
on. Yeah. So, and so for now, for the purpose of this, it sounds like it's just insomnia symptom. That's it. And I
Mhm.
would define
Okay.
that.
Okay.
Yeah. It's
Thank
not
you.
a disorder, it's a symptom. Yeah. Thank you. Yeah. And the other thing is, this is just me, throwing it, thinking. So, do you have anywhere in there, how long have they had the insomnia? Like, is it any time frame, or is it just a point insomnia? That's it, like 1 month, 1 year? The reason I ask, because one of the criteria for insomnia is duration. So it's acute versus chronic. So in the sleep literature, acute is less than 30 days. Chronic
Oh,
is more than 90 days. If someone has insomnia for 90 days or more, you call it chronic insomnia,
okay.
and which then has a different treatment plan. So anywhere in your paper or in your research, are you defining your insomnia here as chronic, um, acute? What is it? Do you have any sense of that? Or
Mm, I am not sure if that was specifically like the duration of their insomnia. I know that
yeah.
it was like the
Mhm.
cross section. So we asked them at one given time, but I'm not sure
Yeah.
the length of time
Yeah.
that
Okay.
we asked or specified for that. But that
Sure.
is something that is another thing that'd be very interesting because it's nice to know the chronic versus the acute because I feel like that could dictate what avenue you want to research
Sure.
down.
So I would define that too. Because if
Gotcha.
asleep, I say it only because I bring it up so that you define these definitions would fit a little bit more in line with maybe the sleep literature. So I would define that you did not seek or find or ask about duration of insomnia, or this is in one point in time, therefore you cannot assess this was an acute or chronic. According to International Classification of Sleep Disorder, or you can use the DSM, the psychiatry literature has their own, we can work that out. But I would
Gotcha.
specify that you did not specifically specify whether it's acute and chronic. However, I think I would be comfortable in saying a sentence in there that more likely those patients have probably crossed the threshold for acute. It's, we all know by the time they seek medical attention, it's beyond 30 days. So we can always state that we presume that those patients are not acute, and they fit more into the subacute versus chronic state. And that's an assumption. You can say that.
Okay. All right. Well, be good to add.
I will comment. This is great, Dr. Alatar. Thank you. And
Oh, yeah, sure. My pleasure.
we can definitely be mindful of the feedback I know you've given us before and about the saying insomnia symptoms, because that is what this was referring to, because the ISI is looking at symptom severity.
Yeah.
The stem of the questions typically refers the last 2 weeks or last 14 days. That they don't have to do it like that, but that's generally how it's recommended to be administered. And then these patients, we did do the ISQ, which is again not a diagnostic tool, but it's supposed to be like a research screening tool that's supposed to be more in line with diagnostic criteria. But I can't remember if we had duration of insomnia symptoms in this study. So we'll look into that. If we have that, we can include it. I do know that we changed that for the upcoming studies because you had given us this feedback. So it's going to be better for the lemborexant clinical trial, for example, where Madison did use the ISQ and did kind of adapt it to make sure that we are only including people with chronic symptoms of insomnia.
Okay, cool. Thank you. Appreciate it. Appreciate you taking my feedback. Appreciate that. Thank you so much.
Yeah, and Michelle just put in the chat, it was 30 days for the ISQ.
Yeah. 30 days. Okay. I mean, so that's basically said 30 days, or what you mentioned is, I don't know how the question is phrased, but it's been going on for 30 days, or it started 30 days. It's a little different. We just have to figure that out. Because they're kind of two different animals, acute insomnia versus chronic. They're very different. And I assume most of your population will be chronic. If there's a way to define that, I think that would be better, because then it would justify a lot of these prescriptions. For example, we would not prescribe a sedative hypnotic for someone who had insomnia for 2 weeks. We try to work it out, not to mention there are scenarios, especially grief and death or something like that, an unfortunate diagnosis, we go ahead and give people that. But I would assume in your population, it's more chronic. And if you just want to kind of bring that out, it would be helpful. Yeah.
Absolutely.
That's a great idea. We'll, Austin will get with Michelle and figure out whatever duration variables we do have to at least describe this patient population as much as possible, because it is cross-sectional, just at one-time clinical snapshot.
Sure.
Include those along with the overlapping symptomatologies, like you mentioned. So I think that's a great idea that Austin and I didn't think about.
Is it okay if I ask, I don't know, you guys, finishing up or what? I don't want to take a lot of your time. The melatonin part, is just melatonin. Do you have any more specification on that?
It's melatonin or Remeltion. Those are the two that we saw that were in the list of medication, or the chart abstractions. Those are the two that we had that kind of like fit within the same category that could be pulled out from the other list of medications.
Okay. All right. I mean, what goes through my mind is Remeltion is very, it's FDA approved, prescription and so forth. And melatonin, the issue with melatonin is, it's not controlled. You never know you don't know what you're getting when they go and look at it. So I know that's not what you looked at, but that's something to keep in mind. It's interesting.
Absolutely.
Yeah. And then on the SSRIs, and then you have trazodone, mirtazapine. Is this like there are a bunch of other SSRIs plus trazodone, or are you just saying SSRIs including trazodone and mirtazapine?
There were other SSRIs on board other than the trazodone, mirtazapine, gabapentin. There were some. I believe there was a couple, fluoxetine, uh, sertraline. I believe that was also mentioned there. So it's more of your typical SSRIs, your first line SSRIs within that category, and then we have trazodone and mirtazapine and separated those out from the typical SSRIs that we have.
So the reason I mentioned this is because certain SSRIs like trazodone, mirtazapine do have a sedative side effect.
Mhm.
And there are others that have the opposite, like fluoxetine is a stimulant. If anything, I give it to my patients who are sleepy. So the question is that being prescribed for someone who has insomnia or just happens to be there? You know what I mean?
Yeah, I think that's part of like some of the information that we will be trying to tease out is whether or
Yeah.
not these medications are prescribed for insomnia symptoms or if they were prescribed for other comorbid symptoms that they are experiencing outside of that.
Yeah, I would sort that because the only two from the SSRI that would be kind of prescribed as sleeping pills are trazodone or mirtazapine, and the rest, they must have been prescribed probably for just anxiety or something like that. Something to, yeah. Cool. I think that's all I have.
And also the majority of our sample were women, and we know mood disorders are very common, especially in women and women with opioid use disorder. So yes, we give out a lot of SSRIs at the Motivate Clinic, and so that is very common, primarily for the comorbid mood disorders that people have.
It's interesting. I don't see a TCAs in there, like Elavil or the others. I use it sometimes. They have other comorbidities, but TCAs like amitriptyline, doxepin, these are all. I don't know if you guys have prescribed those.
That'll be interesting to look at to see because more medications, especially medications like those, that'd be interesting to see if maybe piece it out more. Is there more of a pattern that can be seen as opposed to the current classes that we have?
Yeah, or pregabalin too.
Oh, that's another great one.
Yeah, pregabalin, pregabalin. How about just plain old Benadryl?
Actually, no, that one I remember. I think I remember thinking about that as well, but I wasn't sure. When looking at the whole abstract list, I don't believe there were any diphenhydramine.
Diphenhydramine, yeah.
I don't believe there was any used, at least within the abstractions that we saw.
Okay. I don't know if you want to mention and say there's none used. You can do that too, because it is actually in the population, it is a very, very commonly used self-medicated sedative hypnotic.
I believe like the ZQuil, like NyQuil is just diphenhydramine. Yep. And it's marketed just for sleeping. Yeah.
And if you go to the store and you'll see that it's in there as a sleeping pill. So that could be
really
something.
Good point. Yeah.
And then you can say it was not, that was not used. So you not only have the ones used, you can say these were looked into, they were not used, which will be, an additional data point, I guess.
Oh yeah, absolutely.
Yeah.
There was one more hand up that wanted to ask a question.
Yeah, I did. Austin, I was wondering, do you think the correlation between the hypnotics and whether or not they were effective or ineffective for insomnia would be greater if the medications were prescribed by psychiatrists?
That's a good question. I am not I don't know if it would be more like or more or less like correlated or an obvious significant correlation, just because especially when it comes to the OUD, well, this population of interest we were looking at are individuals who are in the Motivate clinic and that were
Mhm.
receiving medication, buprenorphine, at Motivate, who were not licensed and trained psychiatrists or their primary care physicians. But then if you switch the role and say it is their primary care physician or their psychiatrist, that's the way at least it may be different, but the way at least I've looked at it in my head is that it's like a triangle. If you've got the psychiatrist, then you've got the PCP, then you've got the prescribers that Motivate. If you just switch it from they're no longer at Motivate and then it's the PCPs, then do those PCP professionals and those professionals for those participants, do they know the prescribing, regulations and guidelines for OUD medication for like the or the OUD provider at Motivate would know because that's their profession. That's what they're like trained on and very well to do. But then if we look at the psychiatrist, maybe they don't have the PCP background that would also contribute to what we see here, or maybe they aren't trained professionally in the, OUD prescribing and treatment aspect. So I'm not sure if we look at just one, like if we just look at a psychiatrist, if we would see any difference, or if we would just see that it shifted and nothing really changed. It's just that it's a different provider. I'm wondering, I think it'd be interesting to look at maybe dual providers, like looking at like a possibility between people who have like dual provide like go to a psychiatrist as well as a OUD clinic, and then maybe look at the prescribing for those medications in that context, as opposed to one provider prescribing all of these medications when this one provider is nobody's generally
Mhm.
trained to do it all. So I'm
Yeah.
wondering if it would just shift or if it would actually do what you were suggesting and maybe be a significant correlation. I
And then
don't know,
I
but I
guess
think it'd be interesting to kind of pursue.
this is a follow-up maybe for Dr. Martin, but how often are people who have like like people who have substance use disorders, how often are they treated by people who specialize in that? And then like or how often are they treated by just psychiatrists and like what's the difference in their recovery rate between those two groups?
I mean, in general, it depends on what substance use disorder you're talking about. I mean, everyone at Motivate has addiction training of some sort. Because we self-select to work there, I guess. And then, so I don't know if the like treatment outcomes differ by the provider. I don't know that data off the top of my head. In general, these days we're trying to not make it a subspecialty. We're trying to, share the wealth and equip providers across all specialties to treat substance use disorders, including with medications for, medications for OUD.
Mhm.
So that's what we've been trying to work towards in the past decade is equipping providers across OBGYN, PCPs, psychiatry, et cetera. Obviously, there's the leaders in that space are a lot of times in psychiatry and in addiction medicine, if that's not in psychiatry, but it usually does fall in that department. But it's not all supposed to be by those providers.
Okay. Okay, that was it.
Good question. Great. Well, we're at time. Thank you so much, Austin, and thank you everyone for giving such good feedback on this project as it's in its infancy and moving forward. We will probably not do a lab meeting next month because December is just such a crazy time. So we'll probably reconvene in January in 2026. But feel free to reach out to Michelle and me if you have any questions. And thank you again, Austin, for a great presentation.
No problem.
Thank you for inviting me.
Yeah, thanks so much for coming, Dr. Alatar. Happy
Thank
holidays,
you.
everyone.
Happy holiday. All right.